I'm Dr. Uzair, and I will be talking about hypertensive emergencies today. Hypertension is the most common modifiable risk factor for cardiovascular diseases. Most common indication for adults to visit a physician, and its prevalence will continue to increase both among the young because of increasing obesity and in older adults because of longer life expectancy. Hypertensive crisis is a more generalized term. It is not defined by a specific blood pressure reading, rather, it is a clinical syndrome that is associated with acute elevation of blood pressure, and it includes hypertensive emergencies and hypertensive urgency. Approximately 1% hypertension patients may develop hypertensive crisis during their lifetime. Annual incidence of hypertensive emergencies being 1 to 2 cases per 100,000 patients. Higher rates have been reported in African Americans, low socioeconomic people, and in developing countries. Incidence in men is 2 times higher than in women. Hypertensive emergencies are characterized by severe increase in systolic and or diastolic blood pressure associated with signs or symptoms of acute and organ damage. No blood pressure threshold is required for diagnosis, but usually systolic BP is more than 180 mm of mercury, and diastolic blood pressure is more than 120 mm of mercury. Mean arterial pressure is more than 180 mm of mercury, requires an immediate BP reduction in few minutes to hours. It requires ICU care, IV drugs, and it may be life-threatening as mortality is up to 20% if untreated. And it requires immediate but careful intervention. Different organs may show different uh, symptoms. In brain, there may be stroke symptoms, agitation, delirium, head injury. In eyes, visual disturbances, papilledema, flame hemorrhages. In heart, chest pain, MI. Um, um, in There may be back pain or signs of aortic dissection. In lungs, there may be patient may show dyspnea or pulmonary edema. There may be acute kidney injury. There is preeclampsia, and also another cause is hyperadrenergic drugs. In emergencies, hypertensive emergencies, the presentation is mostly ischemic stroke with up to 24%, pulmonary edema 22%, hypertensive encephalopathies present as 16% cases, acute heart failure 14%, acute MI 12%, intracerebral hemorrhage is 5%, eclampsia up to 5%, dissecting aortic aneurysm 2%. Others presentations are subarachnoid hemorrhage, acute renal failure, pheochromocytoma, clonidine withdrawal, amphetamine, LSD, or cocaine use. Most common underlying causes of hypertensive emergencies are essential hypertension, up to 90%, untreated hypertension, and drug withdrawal is included in this 90%. Renal hypertension, malignant hypertension, pheochromocytoma, preeclampsia, and cerebrovascular disease are other underlying causes. Pathomechanism of hypertensive emergency is not fully understood, but following abnormalities are involved in the development of hypertensive emergencies. There may be generalized vasoconstriction, cerebral edema, spasm of cerebral vessels, activation of renin-angiotensin system, and activation of sympathetic adrenal system. A patient may present with acute severe hypertension. There may be end organ dysfunction, or may not be present. If the end organ dysfunction is not uh, present, patient can be initiated on antihypertensive medication, or if he is already on antihypertensive medication, the dosage can be increased, and after BP is controlled, he can be discharged. Uh, if patient is showing signs of CNS like altered mental status, focal neurological deficit, or intractable vomiting, workup should be done. There should be CT head, CT brain and neck, MRI brain. They may show ischemic stroke, intracranial hemorrhages, or hypertensive encephalopathies. If there is ischemic stroke, labetalol and nicardipine can be used, and the goal is uh, if the BP is less than 185 by 110, um, then then the patient may be a candidate for thrombolysis. If the BP is more than 220 by 120, then he is a non-candidate. In intracranial hemorrhages, nicardipine can be used, and the goal is in hemorrhagic strokes, it is less than 140 mm of mercury. In subarachnoid hemorrhages, the goal is less than 160 mm of mercury. In hypertensive encephalopathies, nicardipine can be used. Um if there is decreased urine output, renal symptoms should be renal involvement should be suspected, and workup should be done. Basal metabolic profile and urine analysis should be done. Basic metabolic profile and urine analysis. Acute hypertensive nephrosclerosis may be present, and for this condition, phenyldopam can be used. In the first hour, reduce blood pressure by 10 to 20%, and over 24 hours, reduce additional 5 to 15%, or up to less than 160 by 110. There may be cardiac symptoms like chest pain, dyspnea, back pain, chest X-ray, ECG, and troponin. CT angio chest can be done. Findings could be acute coronary syndrome, acute heart failure, and aortic dissection. In acute coronary syndrome, nitroglycerin can be used. In acute heart failure, nitroglycerin again can be used. In aortic dissection, esmolol and nitroprusside are drugs of choice. The goal is to immediately bring down the heart rate to 60, less than 60 beats per minute. Once target heart rate is achieved, systolic BP should be maintained between 100 to 120 mm of mercury. If there are if the patient is pregnant, and there may be symptoms like headache, visual disturbances, seizures, typically the pregnancy is more than 20 weeks and less than 60 weeks postpartum. CBC, metabolic profile, LFTs, urine analysis, and protein creatinine ratio should be done. Um, it may show preeclampsia or eclampsia. And in this, the drug of choice are labetalol and hydralazine. A goal is to immediately reduce the systolic BP to less than 150 mm and diastolic BP between 80 to 100 mm of mercury. Treatment strategies. Sometimes immediate treatment is needed before diagnostic tests are completed or before laboratory tests are available, but top priority is not to do any harm. Treatment of hypertensive emergencies is immediate therapy, prompt lowering of elevated blood pressure within 60 minutes to avoid and limit the risk of serious complications like cerebral hyperperfusion, aortic dissection, increased ICP, controlled lowering of elevated BP to a safer non-critical level, but not to normal range. Reduction of mean arterial pressure should be by 25%. Aim for systolic BP between 160 to 170, and aim for diastolic BP between 100 to 110 mm of mercury. Avoid sudden drop of blood pressure and reduction of cerebral perfusion and development of brain infarctions. Close observation and inpatient treatment is required. Goal BPs in special presentation. If a patient presents with aortic dissection, systolic BP should be maintained below 120 mm in the first hour. In severe eclampsia, it should be reduced to less than 140 mm of mercury in the first hour. In pheochromocytoma crisis, it should be reduced to 140 mm of mercury in the first hour. And in intracranial hemorrhages, systolic BP should be reduced to less than 140 mm of mercury in the first hour. And in ischemic stroke, reduce the systolic BP to less than 180 and diastolic BP to less than 110 mm of mercury in the first 24 hours. Different drugs of choice in the in different clinical presentations. For ischemic stroke, first line drugs are nicardipine and labetalol. Alternative drugs are uripidil. In hypertensive encephalopathy, in the first line and alternative drugs are the same. Also, in intracranial hemorrhages and subarachnoidal hemorrhages, same drugs are used. In acute MI, nitroglycerin is the drug of choice, and alternative is uripidil. In pulmonary edema, furosemide and nitroglycerin is used, and alternative is uripidil. In eclampsia, nicardipine and labetalol are first line drugs, and hydralazine is the drug of second choice alternative drug. In dissecting aortic aneurysm, esmolol with nitroprusside or nitroglycerin or nicardipine is used as first line drug, while labetalol is the alternative. In acute renal failure, furosemide and pheneldoparm is used. Alternative drugs are nicardipine and uripidil. Pheochromocytoma, we use phenoxybenzamine orally, and phentolamine is the alternative drug. Hypertensive urgency is severely elevated arterial BP of systolic BP of more than 180 and or diastolic BP of more than 120 mm of mercury without evidence of acute uh, target organ damage. It has less severe prognosis than hypertensive emergencies in spite of severe hypertension. Most of the hypertensive crisis presentations are hypertensive urgencies. Immediate therapy is gradual lowering of elevated BP within 24 hours to avoid development of serious complications, and controlled lowering of elevated blood pressure, reduction of mean arterial pressure by 25%, aiming for diastolic BP of 100 to 110 mm of mercury, and to avoid sudden drop of blood pressure and cerebral hypoperfusion. Outpatient treatment is possible in hypertensive urgencies. Symptoms of hypertensive emergencies and urgencies. This is a comparison between the two conditions. In hypertensive urgencies, mostly patients present with headache. It is up to 22%. Epistaxis is present in 17% cases. 9% patients may present with somnolence. 9% patients present with chest pain and dyspnea. Neurological deficits may be present in 7% cases. But in comparison, in hypertensive emergencies, chest pain is more common, up to 27% cases. Dyspnea is also more common. It is present in up to 22% cases. Neurological deficits are present in 21% patients. Somnolence is almost the same, about 10%. There may be 8% patients presenting with paresthesias, and up to 12% patients present with nausea, vomiting, dizziness, and headaches. In conclusion, hypertensive emergencies and urgencies are clinical presentations associated with severe elevation of BP, which needs to be lowered immediately or gradually to prevent brain edema and increase in ICP but controlled aim should be systolic BP of 160 and diastolic BP to 110 mm of mercury to avoid sudden drop of BP and reduction in cerebral perfusion. Differential diagnosis should be considered before starting possible harmful treatment, and medical treatment should be started according to the clinical presentation. This slide it shows the um, um, breakdown of all this presentation. Um, Initial workup is based on symptoms. If the patient is asymptomatic, he may be labeled as hypertensive urgency, and he can be treated as a outpatient, and on it may be needed to uptitrate the per oral antihypertensives in case he is already on antihypertensive medication. Evaluate for secondary causes of hypertension and follow up BP monitoring and counseling. If there is a patient, if the patient is symptomatic, initially workup can be based on symptoms. Um, uh, Workup should be done based on the symptoms, and if there is any end organ damage like heart failure, acute MI, aortic dissection, any kidney injury, hypertensive retinopathy or encephalopathy or signs of stroke, it may be labeled as hypertensive emergency. A patient can be transferred to ICU. Care for ABC should be done. Urine output should be monitored, arterial blood pressure and monitoring of vitals. IV and antihypertensives can be started to lower the BP up to 25% in first hour, then lower than 160 by 100 mm of mercury in next 2 to 6 hours, then to baseline over next 2 days. Once BP is controlled and target BP is achieved, we can taper and switch to per oral after 8 to 24 hours. Exception to rate of BP decrease is in um, aortic dissection. Systolic BP should be decreased to less than 120, and heart rate should be less than 60. Within 20 minutes, ischemic stroke without TPA, permissive hypertension to less than 220 by 120 for 48 to 72 hours. An ischemic stroke with TPA less than 185 by 110 and maintained for 24 hours. In hemorrhagic stroke less than 140 to 160 within 1 hour, and in ACF less than 140 within 1 hour. Then there are different drugs which can be used according to the conditions. Thank you.